Hello, and thank you for stopping by my poster. My name is John Bleeker. I'm one of the medical oncologists here at Sanford Health in Sioux Falls, and going to give an interim update on a trial that we are running both in Sioux Falls and Fargo, Sanford Health sites, funded by a DaCCoTA pilot grant. It's entitled Investigating the Utility of Circulating Tumor DNA and Predicting Outcomes Following Definitive Multimodality Therapy for Locally Advanced Esophageal and GE Junction Cancer. A bit of background. Locally advanced esophageal and gastroesophageal junction cancer is a commonly seen diagnosis in our clinic. Our standard treatment is chemoradiation together for some number of weeks, followed by surgical resection. As you can see, cure rates with this approach are less than we'd like them to be, with less than half of patients obtaining cure. And there has been much controversy as to the best way to manage these patients. One of the sites of controversy is whether surgery really adds benefit. There have been some retrospective reviews that have argued that surgery does not add much in the way of survival after chemoradiation, but we certainly know that it adds morbidity in terms of the patient's diet, GI symptoms, et cetera. Because of this, there have been numerous attempts to find a biomarker or multiple biomarkers that may predict which patients may do well without surgery, and also to help predict long-term outcomes in patients so that we can move the field forward and try to find those at highest risk for recurrence after surgery, and then utilize new strategies in those patients. This pilot study looks to investigate a newer biomarker, namely circulating tumor DNA or ctDNA. Just like the name says, there are fragments of DNA that are shed into the blood from a primary tumor, can be detected easily through blood-based testing and can be followed serially through time. This has been studied heavily in multiple different tumor types, and our goal in this pilot project is to investigate whether serial evaluation of circulating tumor DNA in patients going through a course of treatment for upper GI cancer can be informative in terms of outcomes. Our schema, as outlined at the bottom of the poster, shows that we will be drawing blood-based ctDNA testing at the time of diagnosis, and then pairing that with solid tumor genomics at the same time to see how well the circulating tumor DNA and solid tumor genomic evaluation correlates. We will then be also evaluating ctDNA following chemoradiation and following surgery. One of the goals here is to determine how ctDNA levels fall throughout the course of treatment, and so we'll be comparing those levels at different points through that serial evaluation. Spinning this ahead long term, the thought process here is that if ctDNA can be demonstrated to be a good predictor of outcomes, there are patients who, for instance, if they have positive ctDNA testing prior to chemoradiation, which then clears following chemoradiation, that may be a group that we could spare surgery. On the other end of the spectrum, if you have patients where ctDNA positivity persists throughout chemoradiation and then even after surgery, that would be considered a high-risk group. That would likely be a great target group for further treatments in the setting of clinical trials to try to improve outcomes. We have 4 of a planned 20 patients enrolled right now, with more being approached as we speak. We are hopeful to have full enrollment by the end of this year. So I thank the DaCCoTA group for their grant funding. My email is at the top of the poster. If anyone has questions or concerns regarding this project, would certainly be happy to chat with them. And thanks again for stopping by.